Hello, I'm Will Green. I'm a Project Director within the Health Economic Modelling team here at YHEC, and I'm going to do a webinar on treatment sequence economic models. Treatment sequence models can be used to facilitate economic evaluations within indications in which there are multiple treatment options that can be used one after another. They are particularly common in chronic conditions where there is no permanent cure, so for example rheumatoid arthritis and plaque psoriasis, but they are also expected to become more common within acute diseases where treatment failure is common as new therapies emerge within that particular type of disease, so for example early stage cancer. These treatment sequence models are vulnerable to the same issues as other types of economic evaluation, so for example how we overcome a lack of long-term effectiveness data, but there are also specific issues associated with treatment sequence models, and it is these issues that I will cover throughout the rest of this webinar. The first topic to consider is best supportive care, also sometimes known as salvage therapy, which is generally used as the last treatment option within a sequence. And because it is the last option, it is usually common across all the different sequences that are analysed, making it a key driver of the results. Often, if you simply delay a time until a patient gets to best supportive care, then this will be beneficial because it is a treatment option that can be associated with high costs and low QALYs. However, in reality, there will often be debate about what best supportive care actually consists of and whether it is even a viable treatment option at all. If we take the example of plaque psoriasis, best supportive care has commonly been applied in previous submissions to NICE within this indication. However, clinicians have argued that it isn't even a viable treatment option, and in clinical practice they would simply circle patients around all of the available active interventions. If there is no well-defined final stage, such as best supportive care, then this could lead to its own issues. Because there is no well-defined final stage, then that means you might ultimately have to model many different iterations. Now we need to consider how to present and interpret the results of treatment sequence models. If we take the example of 7 interventions in a 3-stage sequence, then as you can see from the slide, this would lead to 210 possible permutations, i.e. 210 different sequences, and that would be an awful lot of results to actually present. If we fix the last stage in the sequence, i.e. by making it best supportive care, then that would reduce the number substantially to 42. Just sticking with the example of 210 though, it would not be feasible to report all 210 sequences and then present the results in a meaningful way. So for example, how would a NICE committee member interpret the results from 210 different sequences? Because of this, we need to narrow down the number of sequences to provide focus to the analysis. But this obviously provides incentives for manufacturers to select the sequences that are most beneficial to their therapy. To avoid that, we would generally seek to get input from clinicians who could advise on the most appropriate sequences that they actually see in practice. The last thing to consider is how we actually determine whether a new treatment is cost effective given the large number of sequences that are available. So for example, does the new treatment have to be the most cost-effective option, i.e. more cost-effective than all other sequences where the new treatment is not included? The next issue to consider is how we include data on treatment effectiveness, and in particular, how does a treatment's position in the sequence impact on its efficacy? The problem that we have here is that most trials focus on discrete therapies and not full patient pathways. That means we don't have data on the impact of the positioning. Instead, we'll just have the data for the treatment in one particular stage in the sequence, usually the first stage before they previously had any sort of active therapy. So what options do we have to overcome this? Well, the most simple one is simply to assume that the place in sequence has no effect on the overall efficacy, i.e. a treatment will be just effective no matter which stage in the sequence it is placed. And in fact, we have research to show that this is the most common approach. Zhang et al. 2017 found that in the majority of previous NICE submissions that used a treatment sequence approach, the efficacy did not vary by position in sequence. In reality, it is likely that a treatment's position in sequence will affect its efficacy, as we can see in this table here. This is from the example of plaque psoriasis, and you can see highlighted in red is the column that shows treatments in which the patients have previously been exposed to biologics. So this would be equivalent to the treatment being given second line as opposed to first line. And as you can see, the efficacy is much lower in those patients who have previously been exposed to biologics as opposed to bio-naive patients, i.e. first-line patients. For that reason, if possible, we need to examine the impact of previous exposure using trial data that may be available, really so we can adjust for the potential drop in efficacy as treatments are used later in the sequence. As I just mentioned in the previous slide, the issue may be actually finding that data because it may not be reported in trials. One way to overcome this may be to use registry data, which will often report on the impact of previous exposure. However, this registry data will usually only be available for older treatments and not new treatments, which are maybe the ones that we are hoping to assess as part of the cost-effectiveness analysis. I'm just going to finish with describing two more issues associated with sequence models. Firstly, often there will be multiple HTA submissions within the same indication because there are such a high number of therapies within that area, and this means any new submission is likely to lean heavily on the methods that have been applied previously, particularly if the drugs were approved by the HTA agency within that indication. What this means is there is often a lack of innovation and a repeating of previous errors, so those errors just get compounded in the future, which is obviously something we would want to avoid. Second of all is the rebound effect. The rebound effect captures changes in health after discontinuation, and this can have a large impact on results, but it is not always easy to model correctly. So, for example, has the patient's health declined due to the discontinuation from the treatment, or in fact have they actually discontinued because they've already declined in health? In certain models, you may actually capture both of these events separately, which can lead to double counting and an overestimation of the decline in health, which will obviously have an impact on the overall cost effectiveness estimates. So to summarise, treatment sequence models can be developed when there are multiple treatment options available within the same indication, and these treatments can be given in sequence. And these are common in chronic conditions. There are unique characteristics to these sequence models that need to be considered carefully whenever you are going to assess a new intervention using this approach. So, is best supportive care a suitable option in the pathway, and can it be accurately defined? If there are many treatment options available, how do we narrow down the number of sequences in order to provide focus to the analysis? How do we find appropriate data for all elements of the sequence, and in particular efficacy data for each position in the sequence? And lastly, has the rebound effect been captured in an appropriate way? If you would like any more information about this webinar, please use the contact details shown on the slide. Thank you for listening.